Pathogenesis of photophobia. Photophobia is a sensory state in which light causes discomfort in the eye or head. It may also cause an avoidance reaction without overt pain. The term originates from two Greek words, photo, which means light, and phobia, which means fear. Therefore, photophobia means abnormal sensitivity to light, especially of the eyes. It is reported in almost all forms of migraine and many neuro-ophthalmic disorders. There are many ocular causes of photophobia as listed here. In addition, the non-ocular factors can also cause phobia. The trigeminal nerve and its nuclei are the primary mediators of pain sensation to the head. The conjunctiva, cornea, sclera, and uvea are densely innervated with trigeminal fibers. Any painful stimulus invariably causes photophobia. Extraocular muscles have nociceptive efferents that travel along cranial nerves 3, 4 and 6, leading to pain and photophobia with oral myositis, diabetic third nerve palsy, orbital inflammation and superior orbital fissure syndrome. The trigeminal-vascular and trigemino-autonomic reflexes are thought to underlie the conjunctival injection, tearing, and periorbital pain of migraine and cluster headache, also accompanied by photophobia. The blink reflex is a response to stimulation of the cornea or face, and also induced by light and auditory stimuli, and distant somatosensory stimuli. Each stimulus-induced reflex has individual wiring features, though all have in common motor outflow through the 7th cranial nerve. Photophobia causes an increase in blinking, and conditions associated with blinking abnormalities may cause photophobia. There are 3 types of photophobia circuits involved. The ganglion cells project light-related signaling to the olivary pretectal nucleus, whose projections activate the superior salivatory nucleus, causing ocular vasodilation and activation of ocular trigeminal efferents, which are heavily expressed on blood vessels. These efferents, with cell bodies in the trigeminal ganglion, project to trigeminal nucleus caudalis, thalamus and cortex. In the second circuit, the intrinsically photosensitive retinal ganglion cells project directly to thalamic neurons that also receive intracranial nociceptive afferent signal neurons in trigeminal ganglion and trigeminal nucleus caudalis. The thalamic neurons fire in response to light and pain stimuli, and their output projects diffusely to sensory and association cortex. The third circuit, melanopsin-containing, intrinsically photosensitive ganglion-like cells, may explain the fact that light can activate trigeminal blink reflex even after the optic nerve has been sectioned. All 3 circuits may interact at different locations. Calcium gene-related peptide receptor may be a possible molecular target in photophobia. Trigeminal-vascular efferents both release and respond to CGRP, which is both pronociceptive and vasodilatory. Because of its prominent role, it is a target for acute migraine treatment. Many photophobia circuit alterations in humans may lead to photophobia. Every individual has a threshold of light sensitivity, and subjects with migraine and even tension type and cervicogenic headache have lower thresholds, explaining their photophobia. Light sensitivity can also depend on the season. Lower pain thresholds to light in the winter months than in the summer months can lead to photophobia. State of retinal adaptation can also result in photophobia. Shorter wavelength, blue, light was more uncomfortable than longer wavelength, red, light in migraine patients, suggesting their association. Due to the complex pathophysiology, the diagnosis of the underlying cause of photophobia may be difficult. Physician can be guided by the shown algorithm for reference.